Thank you, Gilda, and thank you to all of you for inviting me to join you here this morning and to kick off this important policy colloquium. I'm particularly pleased because, as I was saying to Gilda before we started, the President's Council is a council of independent science advisors to the President and responds to requests from the administration and often personally from the President himself to answer questions that relate to national policy and things that the administration can move forward. And he is very insistent that these reports not be academic reports, no offense intended, that sit on a shelf, but that they actually be, as much as possible, turned into action. So this is an opportunity for me to tell you about this report, and you're the folks who actually could help make this happen. So I'm very interested in hearing from you and just would offer, I'm based here in Washington now at the National Quality Forum and happy to engage afterwards in conversations if people are interested. So the first thing I would say is of these 20 scientists on the President's Council, there are numerous engineers among the group and a whole range of engineering disciplines. I won't go into them. Because it's such a relatively small group, and I'm the only physician in the group, when we take on an issue, we bring working groups together. So we bring people from outside of the President's Council. So in this case, our working group on systems engineering and healthcare was co-chaired by myself, Ed Penhut, and Maxine Savitz. And many of you probably know Maxine, who's Vice President of the National Academy of Engineering. The other PCAST members include Richard Levin, an economist and President Emeritus of Yale, Bill Press, a professor of computer science at University of Texas at Austin, and I think the rest of the members of the working group are not PCAST members, but are people who come from both engineering and healthcare. So now I don't need to give you this definition. This is kind of a plain English definition of what is systems engineering, an interdisciplinary approach to analyze, design, manage, and measure a complex system of any kind with efforts to improve its efficiency, productivity, quality, safety, and other factors. So many industries have used systems engineering approaches to reduce waste and improve reliability. In healthcare, some institutions have really invested in this. Most of them, some of you may have heard, for example, Virginia Mason, Denver Health, Geisinger, invested in the lean method, the Toyota lean method, or the GE Six Sigma method, or ISO 9000, or some of these other methods. We became aware through this study that there's lots of different ways of thinking about it. You don't have to buy just one approach. But where these methods have been used, and used thoroughly, there have been dramatic, successful results. And I don't have those here, but if you go online, or I'd be happy to send it to you, and read our report, we have a lot of documentation about the results in improving patient safety and reliability and reducing cost. But the problem is, and the problem that the administration asked us to address, is that these are isolated instances. These practices have not spread very widely, and the question is why. So we addressed those questions, and we came up with this group of 6 recommendations, and I'm just going to go through them pretty quickly, but focus on some of the education recommendations. So the first was to accelerate alignment of payment systems with desired outcomes, better care at lower costs. So one of the reasons why these methods haven't spread is that we uniquely actually pay for mistakes in healthcare. We pay for waste, we pay for redundancy, and we don't pay for better outcomes by and large. That's beginning to change, but that's why our #1 recommendation was to accelerate those changes. Second, increase access to relevant health data and analytics. I'll tell you more about that. Third, provide technical assistance in systems engineering approaches. 4, involve communities in improving healthcare delivery, and that's viewed as part of a system. If you're talking about the complex system that makes healthcare work better, there are many, many aspects of what happens not in the hospital or the doctor's office, but in the community that can really help improve outcomes. 5, share lessons learned from successful improvement efforts. And 6, train health professionals in new skills and approaches. And that's where I want to spend probably most time. But let's start with this. I apologize that the last line is kind of off kilter there, but hopefully you can read it. The recommendation number 1 was about the payment incentives, and I sort of told you in a sort of broad way how the fee-for-service model of paying for healthcare is what we now call pay for volume, not for value. And so there are beginning to be now, under the Affordable Care Act, innovative approaches to different ways of paying, alternative payment models. Some systems in the country, such as Kaiser Permanente and others, have already begun and have actually years of experience in being paid a flat amount to take care of a population of patients, so they have an incentive to become more efficient. What's needed, of course, if you're going to pay for value, is you have to be able to define it, and you have to be able to measure it, and it has to be transparent, and it has to be credible. So we now are, that's one of the things I do in my role at the National Quality Forum, is work on making systematic and standardized the measures of quality and safety and efficiency that are used in these new payment models and that are made available to consumers. So part of what's needed is better measures then of care. If you're really going to push this model, we have a lot of measures of quality of care now, but we need better measures of the outcomes and of the value, so the cost and quality equation. Recommendation number 2, accelerate efforts to develop the nation's health data infrastructure. Well, so the first thing is we've now made a big investment, actually not the Affordable Care Act, but before that, the High-Tech Act that was part of the Recovery Stimulus Act during the recession of 2008 made a major investment in getting hospitals and physician offices to develop, to adopt and use electronic health records. This has not gone totally smoothly. You may have heard some of the difficulties that have been encountered, but nonetheless, it now is the case that the vast majority of providers of healthcare in all sectors, with some unfortunate gaps in the long-term care area, which is something that really has to be addressed, I think, in the next round. But the trouble is that these electronic records, by and large, are not interoperable. They do not speak to each other. They don't exchange data easily. PCAST put out a report that I co-chaired in 2010 on ways that we could get the health information technology to be more interoperable. These are computer technologies, not legal documents, because right now it takes one electronic record talking to another electronic record, and it's like unilateral trade agreements rather than having a technical solution through computer science to how this could be done more smoothly through basically open interfaces. The same recommendation, a somewhat different version of that, was made in a 2014 Jason report to the Office of the National Coordinator for Health Information Technology, and I think we're beginning to see some movement in that direction. Recommendation 3 under this second goal is that there needs to be national leadership in systems engineering. We need to have, within HHS, if you look at HHS, it's by far the largest agency, if you will, of the federal government, but it's really all these separate agencies. It's the FDA, it's the Centers for Medicare and Medicaid Services, it's the NIH, it's the CDC, and a whole range of others as well. And they all have their own information systems, and they all have massive amounts of data, and they don't really talk to each other. or share that data. And it's just developed that way over time. And so we recommended that there be a senior position within HHS that would be responsible for bringing all of that data together as much as possible, and then making it accessible to people who could do analytics with it and actually make it meaningful to providers on the ground in communities at a regional level to understand the health of populations, the specific dynamics in a given area, some of the kinds of information that are really essential to drive systems engineering. Recommendation 4 was that we increase technical assistance to healthcare professionals and communities in applying these approaches. Now, this is really an important one because most of us, most physicians, nurses, even hospital CEOs, weren't trained in systems engineering. Sometimes you're trained in how to run a business and you have an MBA. You may have some ideas about systems engineering, but in terms of quality improvement science, the use of real-time dynamic data loops in order to actually drive improvement and set targets, know what you're getting to, and bring people together around those goals are not things that most physicians are used to. And when my colleague, for example, Gary Kaplan at Virginia Mason or Patricia Gabo, who's CEO of Denver Health, go around and give talks to medical audiences about this, they always get the same reaction, which is that, well, we take care of people, we don't make cars. So it's much more complicated taking care of people than making cars. And they sort of, blank out the idea that there would be a systems way of doing it. It seems kind of impersonal and very just culturally different than how they think about what they do in healthcare every day. And yet, once they experience how systems engineering actually can make it better for the patient, more personalized. Standardization allows you to actually make it more personalized for the patients who is in front of you, and lower waiting times, make sure that you have accurate information about that patient when you see them, and that you lower the risk that something goes wrong, that you have a wrong site surgery, or the patient gets the wrong medication, or errors of that sort. So it's going to take a culture change within healthcare to begin to spread this more broadly. And one of the things that helps is if people feel competent in this science that's unfamiliar to them. So we're recommending that there be a hands-on support, kind of like the regional extension service that the agriculture department developed in the early days of scientific agriculture, and that actually was, the same model was used when we began to get electronic records in doctors' offices, to put people on the ground with technical skills who could really help educate providers and not wait for the pipeline of people to be trained differently in medical schools, but really provide the help right now. The fifth recommendation was related to communities. Now, this may not seem like an engineering thing, but as someone who's studied complexity science, I can tell you that communities have a lot to do with how efficient your healthcare system is. First of all, there's differences. There are small and rural areas where there's one hospital and basically one health system. There's places like New York and Philadelphia where there are dozens, and each poses its own challenges and how you can make use of community resources in having better information to the providers, but also better information and access to the patients and their families. So health care and health information can be provided now, and often, increasingly is, in the workplace. People don't want, employers don't want people to have to take time, a whole day off just to go to a doctor's appointment, particularly if it's something simple. We now have drugstores, CVS, Walgreens, that are convenient, efficient places to take care of simple problems. Now, if those could be connected to the place that actually provides more complex care, UCLA is experimenting with this with CVS now. So schools, faith-based organizations, all kinds of community organizations can be very helpful in providing health care and providing education for patients and connecting people when they need to be connected to the healthcare system, but helping keeping them out of the healthcare system when that's not what they need. So that's part of what communities can really add here. And then, of course, recognizing success. You know, this is in all of the PCAST work that we've done on STEM education, some of which I'm sure you're familiar with. Many of the things we recommend are, let's give some awards. Let's recognize success in this area. It's not an expensive thing to do, and it really does make a big difference and helps to change a culture. Well, it happens that in the Department of Commerce gives Baldrige Awards, named after Malcolm Baldrige, Secretary of Commerce during the Reagan administration, which was intended to award companies that adopted, at that time, the Japanese techniques, because they were so much more effective, particularly in the automobile industry, in developing reliable and affordable vehicles. But the whole science of quality improvement really developed under that, under the auspices of the Baldrige technique and the Baldrige criteria for what a high-performing, high-quality systems engineering method is. And interestingly, over the last 10 years, more and more healthcare organizations have been the recipients of the Baldrige Awards. And that makes more and more others want to do it, because we're all competitive, of course, you know, and if the hospital on the other side of town gets a Baldrige Award, that gives them bragging rights. So, so it's beginning to change the awareness around this. We suggested that maybe we actually went to meet with NIST and talk to them about the award. They're the ones who administer it. That perhaps they should link together with HHS, and the Secretary of Commerce and the Secretary of HHS would jointly give either a glorified Baldrige or some other kinds of awards that would recognize high-performance systems engineering in healthcare. And then, of course, building competencies and the workforce for redesigning healthcare. Well, here's a place where there just is a great need for more education in every aspect of this. And I would say in healthcare education, in healthcare administration education, and perhaps in engineering schools as well. And that's the thought I want to leave with you. We recommend that there be a wide range of funding and partnership levers that could be used to educate clinicians about systems engineering. So you get beyond this thing about we don't make cars and what can we learn from other industries, but really start to get people asking those kinds of questions. And that, some government effort go into promoting, perhaps with education groups such as your own, best practices in curricular and learning activities that could be disseminated. And we also thought that centers of excellence could be funded in innovative programs for health professional curricula. There are two examples of this that I'm familiar with. In the 1970s, when occupational health was just starting to be a new field, the government, so this is workplace health and safety, a lot of issues about keeping people healthy in the workplace and avoiding accidents and exposures that could lead to illness. The government established 10 centers of excellence around the country in different universities, only just 10. And within a decade, you had a whole pipeline of leaders that started a new field that to this day, it's been quite successful. Same thing happened in my discipline, geriatric medicine. In the 1980s, there was no geriatric medicine in the United States. The Veterans Administration looked ahead at its population and wisely looked at the European and British models where they had specialists in aging research and geriatric medicine, and decided to invest in that. And they created programs, I think more than 10, but maybe 15 or 20 programs around the country, and the same thing happened. Very quickly, a cadre of leaders developed that then created and sustained this new field. So we're imagining that you could find universities that had both engineering schools and medical schools and task them with, an adequate but reasonable amount of funding to really develop new programs. I'm thinking from the perspective of medical school, it would be like a fellowship training where people would get some kind of certification at the end of it. Now, there are some of these, so I'm going to show you there's some, these are beginning to develop in different places already. So these are the summary and conclusions. Let me just give you then an update. And we put this report out just a year ago, and some things are beginning to happen. One of the things that we built on was the fact that the Institute of Medicine and the National Academy of Engineering had actually over the last several years developed partnerships on bridging engineering and healthcare, and that helped to really inform and steer our work. The Gordon and Betty Moore Foundation in California had developed an initiative on using systems engineering in healthcare delivery specifically to look at preventable harms, risks to patients who are in hospitals, and how to reduce those risks and increase safety, and using engineering methods to do that. And CMS, as part of the Affordable Care Act, invested in a healthcare systems engineering center at Northeastern University in Boston, and the Office of the National Coordinator for Health Information Technology did establish these regional extension centers. And we do have the Baldrige Awards, although that built-out version of them, has not yet been developed. More recently, it's very interesting, we had a new secretary of HHS, as you know, confirmed just a couple of months ago, and she's hit the ground running in a number of ways, and some of which I like to think reflects some of the recommendations in our document. One is that just 3 weeks ago, she announced that that CMS would significantly accelerate the move to pay for value rather than pay for volume. These new alternative payment models, basically moving from 20% of CMS funding being pay for value to 30% in 1 year by 2016. She said, I want to have a goal when I'm still going to be here. And I thought that was, bold of her and admirable. And that's, a 50% increase in all of CMS programs. That's a lot of funding and a lot of incentive, if you want to think about it that way, to the delivery system out there to begin to respond to these incentives. The other thing is down at the bottom, Niall Brennan, I apologize, that's kind of sort of crossed out, was named the new chief data officer within CMS. And so I think something about our call to have somebody who, and he reports directly to her, and his task is to kind of bring together all the data and analytics resources of CMS that can be applied to more rapid adoption of these systems engineering techniques. And then just a few data points, and then I want to stop and hear from you and allow for more discussion. There are a number of systems engineering programs that are beginning there's a little bit of research that we did at PCAST that were advertised in various online resources. So you can see that there's a very few PhD, a lot of master's, certificate level, and bachelor degrees. The blue is health-related schools, and the red is engineering. So more of these right now are in health-related schools offered through schools of public health, schools of medicine, schools of health administration, or healthcare management. And as you can see, the engineering certificates are at multiple different levels as well. This is probably hard to see, but you can definitely keep this deck and make it available to people. But we looked at schools of engineering that have healthcare systems engineering programs and found these 13 schools. Now, there may be more, so my apologies if we didn't get them all. But as you can see, they're clustered mostly, well, in the Northeast, but also the upper Midwest, 1 in Texas and 2 in California. So there are important models that I think could be built upon and expanded. And so this is just stepping back a little bit and from my perspective as at the National Quality Forum, something that I would welcome your thoughts on and perhaps some collaboration about is how to get to the most meaningful measures that are really going to inform an improvement process. As you know, the accuracy and credibility and trustworthiness of the data is essential if this whole idea of a rapid cycle improvement is really going to work. That certainly is true in the healthcare setting. That the data have to be credible, timely, usable, and meaningful. We now live in a world where these clunky electronic health records are really being outstripped by cloud-based data solutions of many different kinds. We're seeing all kinds of innovation, apps that will pull the data out and report them and sort them out in different ways. We're seeing not a lot of standardization around that, which makes it a little scary sometimes, but hard to know really where to go for the best information. But we're definitely moving into a time where when we're talking about value-based purchasing, we're talking about more transparency, more information to the consumer. If you go to the web now looking for quality of care, it is a jungle out there. You get Angie's List and Yelp as being how you can find a good doctor, right? And there are some rating sites like Healthgrades, for example, and others, but they're black box, so you don't really know what went into them in terms of data. My organization, the National Quality Forum, is dedicated to transparency and creating standardized measures that the government can use and increasingly private payers are using for these payment programs as well as for some of these public report card programs. So we're kind of swimming in this sea of data and trying to develop some standardization so that you can compare apples to apples more or less out there. So it's a very interesting time to be in this world. We're thinking about the idea of an incubator that could use these big data sources to help more rapidly develop measures that matter, measures that really are going to be meaningful and tell people about value rather than just little siloed segments of healthcare. And that's what's down on the left-hand side here. So I can tell you more about that if you're interested, but that's a place where it seems essential for this kind of progress to be made in the healthcare world. The quality and accessibility of credible data is going to be essential. So let me just stop there and open up for questions from you. And some of the questions that I have to do with, you know, this is probably not an either or, but I just put it this way for rhetorical purposes. So, systems engineering training, from your perspective, you're the experts. What do you think about this? Do you think that medical schools are the right place for this? Do you think engineering schools? Do you think we should start bringing, you know, doctors and nurses through engineering schools? Are there what sort of collaborations do you think might be possible or might be difficult? I think having been a dean of a medical school at OHSU where there was a school of engineering that was heavily focused in bioengineering on that campus, I had some experience of some of that kind of collaboration, but I'm also aware of how complex systems universities are themselves, and so interested in your thoughts about that. And then job opportunities for engineers, the people that you educate in health systems. Now, there are some examples of that. Probably the one person who was on our working group was Jim Bajian, who was a flight engineer and systems engineer who rose to prominence in the healthcare world when he came to the Veterans Administration to help design some systems there, I think quite successfully, and he's been gone about 10 years, and I think they've had some issues with losing some of that sharp edge of their systems approaches. But he's now at the University of Michigan in the engineering school there, but he also works with standard-setting organizations for medicine and is beginning to do a lot with them. So that's one example. I also happen to know within the Kaiser Permanente system, there are several people who come from engineering backgrounds who are part of their patient safety program. So that may be another way to think about it, have people trained in engineering. But let me just thank you for allowing me to share this report very quickly with you. As I said, I'm happy to make the full text available, but I wanted to get you started on the day-to-day in really thinking about, even as on your Hill visits, how engineering could really be helpful to one of the most expensive and most controversial things in the policy world right now, which is our healthcare system. And no matter where you stand on all the political questions, it's very clear that we spend the most money of any country in the world, and that we know by every measure that we aren't getting the value we could be getting and should be getting for the dollars we're spending. So thank you very much, and I welcome your questions and comments.
I'm Joe Helbley from Dartmouth College, and I wanted to essentially turn around and ask you the question I think you're asking us, and that's about systems engineering training and where its proper place might be. When I listened to your comments earlier, you described fellowship programs or master's programs, and if we think about it at that level, it suggests that it's additive training that's important for a subset of highly skilled physicians, nurses, and administrators to have. But given the broader remarks that you make, are we moving in a direction where this is essential training for everyone who's going to be a practicing physician or nurse? And if that's the case, I'm asking you as a former dean of a medical school, is there flexibility to incorporate something like that in the medical school curriculum, or even think about some prerequisites you would need to have before entering medical school?
Well, thank you. I think that's a softball question, because it's you're asking me what I think is really essential, and it's actually in the report. I didn't emphasize it in my comments here, that we need to have education throughout, from medical school forward, in systems engineering. So it's not viewed as a kind of foreign thing that just some geeky people decide to do, but it's an essential, it's like a basic science of healthcare, because healthcare is a complex system, and you have to learn that you're part of a system and how to make the system adapt to serve the patient. It's not just anymore that the doctor serves the patient. It's really, people need to understand all of those dynamics. So I think we ought to emphasize that as part of medical education. Medical schools are hard to change. There's been a Renee Fox, a medical sociologist, famously wrote a book about medical education reform called Reform Without Change, because there's constantly curriculum reform and, et cetera, but it's really tweaking around the edges a model that comes from Flexner from 100 years ago. So I think my personal view is that we need a more dramatic point of view. I'm hoping that somebody, there's a bunch of new medical schools popping up now, since there is a prevalent view that we have a shortage of doctors, and regardless of what you think about that, I sort of think if we had better engineered systems, we would probably have enough doctors. But be that as it may, there are a lot of new medical schools where there's opportunities to start from scratch and really try to inculcate. And some of the schools, I think, are doing that. But they don't call it systems engineering. Sometimes they call it systems thinking, systems science. There is one of the competencies that the accrediting body that accredits residency programs has 6 competencies, and one of the competencies is systems-based practice, is what they call it. So there's different words that affect this. But I kind of, and some of my colleagues in engineering think that if you put engineering in there, it's off-putting to the healthcare people. I actually think we should call it what it is and make it a science and say this is, you know, a basic science. To your earlier point about prerequisites, I can tell you from my career in medicine that systems engineering would have been much more important than organic chemistry for me as a physician, you know, and we still require organic chemistry. And so I think that's an interesting proposal. Maybe I'll write a little something about that. Thank you. Yes.
Peter Kilpatrick, I'm from the University of Notre Dame. You talk a lot about quality engineering and the lessons learned from you know, big systems manufacturing. But I wonder if the real low-hanging fruit in medicine and medical costs aren't procedure-based. So, for example, blood tests are typically $300 to $400 a piece and take several days to get the results, right, when in fact they can be done for a few dollars now with equal accuracy. And the only reason we haven't seen this disruption is because of the entrenchment of some of the diagnostic companies. Another example would be triaging, you know, an early case. So deciding whether someone has a throat infection or not. And Sherpa, medical service company in New York, independent physicians, has done this with IT at a fraction of the cost of what hospitals and healthcare facilities are providing. So I'm wondering if your committee looked at the issue from the standpoint of procedures and process and where the real costs are embedded in the healthcare system rather than just from the systems engineering or quality engineering approach.
Yeah. Well, there are many, as you know, there are many, many places where those costs are embedded, and you know there isn't one silver bullet answer to this, and so that's why it's a complex system. But the points that you make about the much more cost-effective diagnostics, the use of telemedicine, the use of patient portals and email with doctors and things like that, all of that, for that stuff to succeed depends on creating a different financial incentive. And that's why this value-based purchasing model, I think, is so important. Because if people are tasked with real meaningful accountability for a population of patients with a fixed amount of money, then they're going to that's a disruptive change right there, and then there's going to be a huge market for those things. I think you're just beginning to see that start to happen now, but it's politically difficult because the medical profession is mostly uncomfortable with those new models because they haven't practiced that way before. It's always been, you know, to just you do more, you get paid more, rather than you find ways to keep the patient from having to come to your office. That actually should be a revenue positive decision, not a revenue negative decision. And yet, I can't tell you how many times friends that I have, you know, you have to go to the doctor to get an answer to a simple question, or, you know, to have the doctor tell you, well, drink lots of fluids and call me if it gets worse, right? Or something like that. It's crazy. It's just crazy. So that's where I think you've got to have the financial incentives aligned to really get a stimulus for. Gary Kaplan at Virginia Mason, who instituted this Toyota process 10 years ago, actually lost money. And he had to make a deal with Aetna, which was one of the prominent private insurers in their area, that they would share, if he saved money for them, would they share some of the savings with him, and they agreed to do it as a kind of experiment. And that's what made it possible for him to do that. But you know, he was actually putting the financial viability of his organization at risk for getting rid of unnecessary, in this case it was treatment of back pain, unnecessary imaging by having the patients go first to physical therapy and see if they got better. Simple kind of technique. So I think you're exactly right that there are lots of those new many techniques, many of which are developed by engineers, the graduates of your schools, and and the markets for them will depend on these payment models changing. Yeah. Okay, well, I just want to, again, thank Gilda and thank all of you for your attention. Welcome your thoughts afterwards, and I'd be happy to be available. Gilda, you can certainly share my email address if people have questions or ideas. I'd love to hear from you. Okay, thank you.